All right, thanks for joining us, everyone. Sorry for this to be delayed a couple of minutes, but we appreciate you joining us for this session. Today, we're going to be talking about telehealth for older adults, looking at principles, guidelines, and some best practices. And I have three colleagues here joining me as speakers. They are representing different organizations, including University of Virginia, Dartmouth-Hitchcock, and Charleston Area Medical Center. So first we'll start off, and I just want to say I have no conflicts of interest to disclose. Quick overview of the agenda. We're going to, each person's going to just stand up and give some perspective and information about themselves, who they care for, where they work, and what they do. And then we're going to go through a set of principles, 3 principles and 18 guidelines that are have been developed to support the provision of telehealth to older adults. At the end of each of those, so we'll go through principle 1, and then we'll have some time for Q&A on that principle, and then we'll go through principle 2 and have some time for Q&A, and if there's time at the end, we'll just open it up for more general Q&A. So first, I'll start with a little introduction of myself. Again, my name's Leanne Wardlow. I'm a director of clinical research at West Health Institute. West Health is a nonprofit, nonpartisan group of organizations that are committed to improving care, lowering costs, and enhancing the aging experience for older adults in America. We have our 3 main organizations are the Institute, the Foundation. This is in San Diego, California, both the Institute and the Foundation. And the Foundation is a grant-making organization. They provide grants to providers and systems and academics who are working towards the same mission as West Health. And then we have a policy center in DC where we work on the policy side. So making sure that at the Institute, the research that we do both informs and is informed by the policy implications. So just a little bit more about the Institute itself. We focus on these 4 different areas. In acute care, we really look at 2 different sides of how you can provide care to seniors when they're having an acute episode. So one is through geriatric emergency departments. So this is a large initiative that we have taken on. There are about 300 accredited geriatric emergency departments in the country to date, most of them at this time in California. And this accreditation is through the American College of Emergency Physicians. We also have a home and community-based acute care group that really studies and focuses on ways of providing acute care to older adults in the home or wherever they are so that they can avoid the hospital and ED when it is appropriate to do so. The group I work with mostly is chronic care, and we work on many different issues since a large number of older adults do live with chronic illness. So we focus on supporting caregivers, both paid and unpaid. We look at different models of delivering care to seniors at home. So this includes things like home-based palliative care and primary care. We look at ways to improve access to and the quality of oral care for seniors, which is a big problem. And we look at ways of improving and expanding the PACE model. That's the program for the all-inclusive care of the elderly. On the supportive services side, we really focus on things like malnutrition and food insecurity, finding ways to identify this problem and address it, as well as advancing whole person care. And then the lowering the healthcare costs, that work really focuses on finding ways to accelerate the adoption of value-based care to make sure that money and incentives are aligned with good outcomes, as well as finding ways to lower the cost of prescription drugs and increase price transparency. Now, you didn't hear me say a lot about telehealth there, but telehealth really does kind of infuse itself across all of these areas. So we do have a telehealth group of which I am part, and we are finding ways to deploy telehealth in all of these kinds of care settings and clinical situations. Now I'll hand it to Lori.
Great, thank you very much. So I'll introduce myself. I'm Lori Archibald Pannoni. I am a geriatric physician at the University of Virginia. I've been working with older adults, over the past really a few decades, in outpatient care as well as in post-acute and long-term care. And I'll tell you a little bit more about our specific program that we rolled out with telehealth at our institution in alignment with the principles. But first, to go a bit more of an overview about the impact of COVID and utilization of telehealth specifically for older adults. As we all know, telehealth really skyrocketed by necessity once COVID hit in spring of 2020. The Office of the Inspector General just put out a brief a few weeks ago to really look at the utilization by the Medicare beneficiaries during the early parts of the pandemic. And what they found was that 43% of the Medicare beneficiaries had used telehealth between 2020 and 2021 with the start of the pandemic. That more than 28 million people in the programs had utilized telehealth, and that's out of the 66 million that are enrolled. This is 8 times the number of people who used it the year before. And that you can see on the graph at the bottom there, that the peak was pretty early in the pandemic, and then it lessened some throughout, but remained high throughout. The most common use was for clinic visits, office visits, but really trying to learn from this experience to see what's the long-term potential for utilizing telehealth for older adults that we could implement to increase access across the spectrum. Next slide, please. Thank you. And this is how they found that the telehealth visits were broken down for the Medicare beneficiaries. As you can see, the majority, were office-based visits, but also looking at 43% were for behavioral health services, which will be an important area to focus on. There were also some that were used for phone-based care, preventive services, as well as nursing home care, which is what our program focused on. And their conclusion from this report was really kind of summed up nicely to say that the changes to the telehealth infrastructure need to balance concerns about access, quality of care, equity, and program integrity to best meet the needs of our patients. And we're really excited to be partnering with West Health and the others on our initiative to try to see how can we best optimize telehealth for an older adult in a variety of settings. So, next slide, I think. All right, thank you very much.
All right. Hi, I'm Katie Darling. I am the Director of Operations for Dartmouth Health, and I have no conflicts of interest to disclose. So this is just a quick overview of Dartmouth Health, New Hampshire's only academic medical center. We have 4 other system member hospitals, 24 outpatient practices, a visiting nurse and hospice center, and then 13,000 employees and over 2,400 providers. For a quick overview of all the services that we offer through our connected care program at Dartmouth Hitchcock, the first is our teleneurology stroke service. We're live with 15 hospitals, and we have transfer rates less than 10%. We believe that those transfer rates is really based on the fact that we have teleneurology services on the inpatient floors as well, so that when they're in the ED and they have that urgent neurology need, they can then admit them and they still have that neurologist available to support them on the inpatient side, which helps keep those lower acuity patients in their community and in their local hospital instead of having to transfer them out. And interesting, only about 50% are actually stroke consults that we do with our teleneurology service. Otherwise, migraine, seizures, plenty of others. Our tele-ICU service is a hardwired bed connection service that we do. It's able to let local hospitals actually double their ICU volumes by keeping those patients local. It also decreases length of stay for those patients. During the pandemic, we started looking at a new model because we found that there were bed restraints everywhere. There were patients in the ED on vents for days while they were calling hospitals to try and move patients out. So we were able to do a cart-based critical care service to bring those critical care doctors into the ED to help care for these patients. Tele-emergency, we have 11 hospitals still avoiding transfer at about 13%. Expedited care for these rural hospitals. One thing that's important for tele-emergency is that with these rural communities, it's rare that they see burn victims or traumas coming into their ED. So by being able to connect to our Dartmouth-Hitchcock physicians who see those kind of patients more frequently, it really helps that care, expedite the service, get them the care they need then to get them transferred out. Telepsychiatry consults, by setting up a telepsychiatry service in one of our local rural hospitals, we're able to reduce the length of stay for pediatric patients that were boarding in the ED by 66%, which is huge, especially for that pediatric population, high anxiety situation being in the ED, and using telehealth to start that treatment plan, medications to get them moving through the system was really helpful. Telepharmacy, 23 live hospitals. Each quarter, they're able to actually avoid 800 medication errors by having the telepharmacist do that med reconciliation for those patients. Tele-ICN neonatology was originally set up to focus in labor and delivery units for those preterm or high-risk babies that are coming in. However, with so many labor and delivery units closing over the past few years, we've switched our focus to EDs. Let's set up tele-ICN in the ED, because even though your labor and delivery unit is closing down, that doesn't mean the patients are going to stop coming. It's an hour, 2 hours now to go to the next hospital. So we really focused on setting it up so that where the patient is, we can come to them and help them with that neonatology care. As many of you have probably also seen with outpatient virtual visits, pre-COVID, we were at 8 to 10 a day. During the pandemic, we spiked up to 2,600 per day. And now we're leveling off at about 600 to 800 a day. Our new virtual urgent care is a program that we started about a year ago. This allows 24/7 access to on-demand virtual visits for, UTIs, URIs, those kind of things that you should not be going to the emergency room for. So let's avoid going to the emergency room for things that can be done with virtual care, reduce the cost of care, and allow the emergency rooms to be able to focus on those higher acuity patients. And then telegeriatrics, something that we partnered with the West Health Foundation to implement. I will discuss that a little bit more in one of my future slides. I'll pass it over to Rebecca.
Okay, so we are a good bit smaller than I think the other folks speaking today. So we're more of a large hospital or a small hospital system. However, you'll see in the news that we are growing. You may have heard recently that we just acquired another hospital system in West Virginia, which will take us, we were mostly Southern West Virginia, and this will take us across West Virginia now. Then we will be called Vandalia Health. So really excited about what's coming forward with that for older adults and telemedicine. Oh. Okay, so how did we build our telemedicine? How did I get in telemedicine? That's probably the question, because I'm more operations and still have a lot of operations. So about 4 or 5 years ago, my boss said, we've got this arm of CAMC that's a community kind of department, and they've got a couple grants for telemedicine. They can't get them off the ground. Will you do them? So number one, I never say no to my boss. I have a problem saying no, period. Mason works with me, he knows. So I have a problem saying no, period. And 2, so the second thing I said was, what's telemedicine? So sent me to some conferences to learn what telemedicine was, and then quickly realized telemedicine's not in our budget. So how are we going to figure this out? How do you buy a platform? How do you get this going for older adults, for anybody, without it being in your budget? So called up our accountant. I'm like, hey, how much does an ER visit cost? Because we're self-funded. So I started going down this road. Is how much does an ER visit cost for our employees? And we argued back and forth of what that was, and finally came to an amount, and then went to the benefits people and said, can you tell me what we're spending on benefits for these ER visits? Was astonished by the data that I got back that said, here's not only what you're spending, but in age groups, and you're going to be surprised by the age group using the ER, well, I was the most, and stratified by unnecessary ER visits. And I'm like, there's my number. So there's my number that I need to work on to be able to provide all of this. So ended up the 20 to 29-year-olds are using the ER more than anybody else of our employees. So we put together an employee benefit package that would save, so we kind of argue a little bit on the numbers, but I think we're around $2 million that we've saved the benefit plan by pushing usage of our on-demand urgent care, which was able to fund all of this and be able to fund for our older adults. Now, I'd like to highlight a couple of things on here. You can read the slides, but a couple of things on here that the hubs are really important for older adults. And I'll go into that a lot into my other slides. But the other thing, and I heard this a little bit in Katie's first talk, was the consult service in our partner hospitals. So there's terrible, awful, lots of competition in West Virginia right now. And we're taking a different approach. Instead of buying all these hospitals, we're partnering with them. So the consult service was, we get this call that says, hey, I've got a crisis in neurology. I need neurology coverage right now. Well, we can probably do some consults via telemedicine. Okay, well, we'll just fill that in around our locums coverage because they're spotty. Then weeks later, after we get started, our hospitalists love it so much, we're canceling the locums. We're just going to use CAMC's neurology service going forward. So those are the kind of the two that I really wanted to highlight. And like I said, we'll talk about the hubs a lot more in my future slides.
Okay, so as we introduce the principles and guidelines today, I just wanted to give you a little bit of context of how these came about. And it's some work that we're just kind of calling the National Initiative on Telehealth for the Aging, where we saw a need and started pulling together some stakeholders to try to make progress on this. And as probably nobody's surprised to see on the left here, here's an infographic from the U.S. Census Bureau, and it's showing the projected growth of older adults in our country, plotted against the projected decline in growth of younger folks in our country. And in about 12 years, it's expected that the number of older adults, and particularly what we call older adults, sort of those over 80, are going to outnumber children under the age of 5 for the first time. So we know that there is a great need to address older adults and their unique medical issues today, but that need is only going to increase over time. Now, when we look at this also in the context of the pandemic and what we've kind of all experienced in the last couple of years, we can kind of get a feel for how telehealth can be used as a tool to support older adults and their medical complexity at this particular time when they're most vulnerable to COVID and are often wanting to stay away from exposures by leaving home and going to medical facilities. So if you look at the graph on the right, it's from the Kaiser Family Foundation, and it's an analysis of Medicare beneficiaries. And on the left, they asked seniors, did your usual provider offer telehealth before COVID-19? And you can see of those who knew, more than half said no. My provider just wasn't even an option. When they asked them, does your usual provider currently offer telehealth? That number of no went down to 13%, and now 64% of providers were offering telehealth to seniors. So this is a huge jump in a very short period of time. And what it said to us was, we need to really understand how telehealth is being used to serve older adults. Where is it being used? What are they using it for? What do we know about how to do it well? To make sure that seniors are really benefiting from this. And also, is everybody getting access to this across the board? So what we did at West Health, we convened a group of folks representing about 30 different organizations. So these are different types of stakeholders purposefully. They represent academic medical centers. They represent senior and patient family stakeholders. There are membership organizations. There are foundations that are focused on older adults and seniors. And we all came together over the last 6 months and through some consensus building exercises, developed this set of principles and guidelines. So this just shows a little bit of kind of where we are in this work stream. This is what we think is going to be phase 1 of this work stream. Again, we identified partners over 6 months. We developed these principles and guidelines. We've also just finished a survey with providers, which we're hoping to release in May. So keep your eyes out for that. We had over 7,000 providers respond. And the idea there was to really get a better understanding of what people are doing now. Who's using telehealth with seniors? How often are they doing it? What are they using it for? And how senior friendly are their practices? And this gives us kind of a baseline understanding of where we are today, as well as where the opportunities and challenges are. At the same time, we're creating resources. So through MATRC, we're going to have a Center of Excellence website where all of the materials that are developed throughout this program and this initiative will be accessible to folks. So keep your eyes out for that as well. So let's get into the heart of the matter. These are our 3 principles. The first one is person-centeredness. So the idea here is that when you're using telehealth to serve older adults, that older adult really needs to be at the center of the decision-making. Their care preferences, their goals, their wishes, their support system, their abilities, and their condition should all be accounted for in that. And I know that that's a lot. I'm seeing faces like, yeah, sure, that sounds easy. Not saying it's easy, this is the goal, right? The second principle is equitable and accessible. So here, regardless of age, regardless of ability, socioeconomic status, literacy, both technological and health, and access, we say all seniors should have equal access to the same high-level quality care. And then our third principle here is integration and coordination. And this is a little more operational, but it says that systems should be set up to facilitate access to the information and support necessary to provide quality care to older adults. And this is both cooperation and communication between and within systems, EMRs, other systems, as well as stakeholders, both at the provider level, but also at the family and caregiver level. So I'm just going to introduce the guidelines. There are 18 guidelines underneath all of these 3 principles. Eventually, we're also going to have another layer down, which will be implementation strategies for each of these. For today, we have this list of 7 guidelines that fall underneath this person-centeredness. After I introduce these, then each of the other speakers are going to come up and talk about their programs and how their programs have addressed these. So again, the person-centeredness really focuses around understanding what's important to the senior or the older adult. This is particularly important, as you know, with older adults who tend to have a lot of different providers who tend to be medically complex and who might be having a telehealth visit with somebody who doesn't have a relationship with them. You know, sometimes it might be their PCP, but it could be somebody else that is beaming in to give them access quicker and may not have access to everything. So we think it's important that they have access to really understanding what the older adult's goals and preferences are. It's also really important that telehealth with older adults supports coordination and continuity of care, particularly as they're changing between care settings. It's important that older adults and their caregivers are prepared and understand what to expect from a telehealth encounter. Older adults often, not always, but often require a little more support on the receiving sort of end of the telehealth visit. And so it's important to think about how your system can do that. It's important to promote opportunities to use telehealth to increase access to care while avoiding avoidable costs or reducing avoidable costs. So this is the idea here, is that sometimes, particularly for homebound or critically ill seniors, it can be really expensive and hard, you know, for them to get to appointments. So really trying to understand where you're deploying telehealth and optimizing using it in those cases where it's a financial and other kind of burden for seniors to get there. Another guideline here is using telehealth to reduce time to see providers across care settings. Again, this is something that has to be balanced with also making sure that you're not further fragmenting their care. And then finally, it's important, and particularly important with older adults, that their families and caregivers are involved and understand and can participate when appropriate and when when that aligns with the older adult's wishes, of course. So I'm going to hand this off to Lori to talk about how her group has done this.
Thank you very much. So our program that we named GeriPOW for Geriatric Engagement and Resource Integration for Post-Acute and Long-Term Care was a program that we put into place anticipating COVID and what it would bring to our long-term care facilities. So in kind of late February, we were starting to learn more about COVID infections, see the devastation that COVID outbreaks in long-term care could bring. And we wanted to see how could we help our local facilities? What could we do as an academic medical center that could provide support during this time that we were going to kind of all be a part of? So we had multiple components to our program, to our intervention. We have ongoing community building Project Echo series for both education and community building. We had an individual, the nurse liaison, who connect directly with facilities to help to integrate our program with their facility. We offered infection control advisory consultation. We connected our medical students who were also on pause at that time with residents in long-term care to have increased social connections. And then we had our option for telemed consultation for either pulmonary critical care, geriatric care, or pulmonary critical care, geriatric care, and palliative care. Sorry. And so to have those ability for the patients to have access, especially when facilities were so locked down in the very beginning of the COVID epidemic. So in working with our patients, like I said, I've been working in long-term care for 15 years or so, and talking with the patients in our facilities, understanding what are their goals, right? How are we going to make this patient-centered? How can we be reflective of these principles of patient-centeredness? And so one of our goals was to have a smooth transfer. So if somebody was going to go to the hospital, how could we optimize that experience for them with COVID specifically? So we implemented our virtual daily rounds with facilities that were undergoing outbreaks, so we could understand who was getting sicker, who may need to be transferred to the hospital. We could then coordinate that with both transport, EMS, as well as the hospital team, so they were ready for them, so that we could, facilitate records, for example. So often in, say, mid to late March, patients would be sent over with a packet of their medications, their comorbidities, their face sheet, all of the information with them, kind of on the stretcher with them. But when they would arrive at the emergency department from a COVID outbreak facility, and we're all very new to treating COVID at this point, those papers were considered contaminated, and so they weren't able to easily facilitate their care as if they would normally. And so understanding that and understanding the need of our patients for a smoother transfer, we were able to help to electronically coordinate between the long-term care facilities and the hospital to ensure that those records were received in a timely fashion to optimize care. We were also then able to coordinate transfers back to the facility by working with the facility while someone's in the hospital to say, this person is coming off of oxygen, hopefully in the next day or two, would you be ready to accept them back in your facility? Would you have staffing? At the time, staffing was extremely difficult, especially during outbreaks. And so ensuring that the facility had the resources to be able to smoothly accept that patient back was something else that we were able to assist with in that goal of a smooth transfer. So those are some examples that we had from our program. And now I will hand it over.
So I'm going to talk a little bit about some of the ways that we were able to support the elderly patients. I like to give cases to kind of tell a story about them. So for this patient, it's a 71-year-old woman admitted to our hospital, receiving discharge information. A physical therapist came in to provide her at-home exercises to do once she gets home. She showed the patient how to do it, but unfortunately, her spouse was not there, or her family members were not there to also see it. In this case, they weren't there because of the visitor policy restrictions due to COVID, but it's common that they can't get there for transportation. They're 2 hours away. It's just not manageable to be there for every visit. So we found that there was a huge gap there. And how can we help support this family so that when she gets home, they can help support her? So we were able to think of this new program that we created called Family Connections. It was an iPad that was able to go into the patient's room, really any room, any patient could utilize these. You just had to enter a text, so your cell phone number for a text message or email address for an email link that would be sent for a virtual visit meeting that you could join. This allowed it so that whenever the patient was alone in the hospital in the evenings, feeling lonely, they could connect to their family themselves, just send them a link, have that visit. That helps them so much when they're sitting there kind of feeling isolated from their family. It helps in their recovery. Along with that, it helps with clinical evaluations and that discharge assistance. We were able to do clinical evaluations this way. So if the patient was maybe in an isolated room, maybe COVID positive, we could bring that iPad in. She could still see all of the same specialists that she would have seen if not positive. It's also for discharge assistance. Patients in the room, they're able to connect their family members into the room. So the family members are watching PT do those exercises with the patient. So when she gets home, they can do them that way. The continuity of care comes in. We have had a few cases where now this patient's being discharged, but she's actually going to a rehab center. She's not going home. Let's have rehab join that meeting as well. So the rehab center, all of the physicians, the family members, everyone is in that same visit to really help that, continuity of care for this patient. Another example would be a 65-year-old male having an outpatient virtual visit with their PCP. The PCP explains the patient diagnosis, provides medications, and then talks about the follow-up needs. In person, when this patient came into the clinic, upon leaving, they were able to see the exit secretary to schedule their video visit, their next follow-up visits in that moment. They were also seeing the nurse on their way out in order to get those prescriptions called in, review them one more time to make sure that they understand how they're taking them. Now in this the MyDH to send it back to patients. Would actually be calling to check in with these patients after the visit. So what had taken place. So once that patient had done the visit, they're able to kind of connect and get those instructions from this person. They also then check in post-visit. So a couple of weeks out, they'll give them a call, make sure you did get those medications, it's going well. Any questions? Did you get that follow-up assistance you needed? An additional benefit to this was actually getting our med students involved. They were currently not doing as much clinical work during the pandemic. So by doing this, the med students were able to get in volunteer hours, but also they were able to still obtain that clinical education by joining these virtual visits. And it's with a specialist, a gastroenterologist, talking to a patient about their Crohn's disease. They're learning more about Crohn's disease, the symptoms of it, management of it, medications of it. So we really found that doubly beneficial in that case.
Isn't this great, you guys? I'm so thankful to be part of this organization, West Health, to be able to learn from these ladies and the whole rest of the group too. This is how we get better, I think. And this is what we need to do. So I just want to say, I think we keep hearing guideline, and I'm going to be really transparent on, what we're doing at CAMC. So we keep hearing guideline, and we all spend a lot of time on specific words that we put in these guidelines, but that's what they are. They're guidelines. So I'm going to be really transparent here about where we're meeting and maybe where we're not meeting at CAMC. So thinking about, here's a few stats about West Virginia. So depending on what poll you're looking at, we're either number 1 or number 3 in geriatric population across our state. And we also we're rural, and we have really terrible broadband. So, so telemedicine gets to be a little difficult when, they don't have access from their homes or anywhere else. So CAMC's answer to person-centered is the Telehub. So these are in-person locations, 2 hours from the hospital, an hour from the hospital, where you can go to see your physician, your specialist, or whatever, to have the kind of in-person virtual visit, if you will. And we feel like we're meeting the patient where they are. So I wanted to talk about, where are we meeting them? So high value use cases, we've got them. We saw an oncology visit last week, tons of cardiology visits with this population. And then I will say too, if you're thinking about older individuals or geriatric population, we've got it covered in all of our, counties, all of our cities and things, wherever we're putting these hubs. So if you're really focusing in on geriatric, you may need to do some research in your state. That reduces time to see the providers, promotes access to care while cutting avoidable costs. Where do we not meet these guidelines? So are we sure older adults are prepared for a telehealth encounter? I think it's probably a little scary actually to say, I'm used to seeing you in person and now I'm going to see you on the TV screen in this office. You're not going to be there. What's it going to be like? I can tell you we've had nothing but positive feedback from them afterwards. So the second visit, I think they're really ready for and they love. The first visit's a little iffy. And am I really going to show up? Am I really going to do this? Do we incorporate the older adults families? We certainly have the capability, but I don't think we've nailed down the process. I don't think we've nailed down, our technology, our platform that we use. We can invite them into the visit. So if, your daughter's working, but, would like to be part of that visit to see what the plan is for the future, we can do it. We just haven't figured out the process for it yet. And I'm sure that we will. The provider reluctance, I think that's a big issue on how do we further telemedicine for the geriatric population. There's this, what I see at my health system is this unspoken rule, or maybe it's even a written rule in some departments of, no, that has to be seen in person. That has to be seen in person, but we can't do that one, Becky. So I think that's a real thing to overcome in the next few years. And as you've seen COVID go up and down, they're not reluctant up here. But when it's back down here, no, that's got to be a person. So I think that we've got work to do there. Let's see. I'm going to go to the next slide. So talking about the hubs, I'd be real transparent with you here and share what's worked and what hasn't worked. So we've got a hub that's a standalone. We rented like a strip mall space and it just works on its own and have referrals into it. And then we've got the embedded clinics. The embedded clinics, unbelievable, because that person working there who's a CAMC employee actually becomes part of their staff. So they're referring in a rural health clinic or even a large, primary care office. That's what's working. The standalone, we may meet back here in a few years and we may not have a standalone anymore. They'll all be embedded. So that's kind of the jury's out on whether that's going to work or not. State laws. So in the ATA considers West Virginia telemedicine unfriendly. We have a state law that says you have to have a visit in person every so many visits, that kind of stuff. So that becomes a challenge to providing care to this group. So what are our successes? The patient testimonies, and I've got one in my slides a little bit further, but we haven't had a negative comment coming to these hubs. In fact, what we hear all the time is, I felt like they focused on me more. They were looking directly at me for all 15 minutes. They weren't fidgeting with the computer or busy doing something else. The nurse navigator. This is, if you take anything from me today, it's nurse navigator. And that's the secret sauce to making this work. Hiring the right person as nurse navigator. This person, if they come in the interview and they say, I don't do registration, I don't do marketing, and I don't do any referrals, anything like that, not the right one. Let that person go. The person this is a utility player. So that's one person working in this center that becomes embedded in that other clinic staff as a go-to person of, I need, Mr. Smith to see a endocrinologist. And then that person becomes the patient advocate back to that provider reluctance. So they're pushing and saying, need to get them in. And then some of the lessons is the reviewing the referrals. So I had a few minutes to pop up one day, and I never have a few minutes. So I pulled up the referrals and started looking through them. And there was a referral where one of the providers said no, but it was a neurology patient who couldn't drive because of, his condition. And so we started, and I'd like to, in my organization, kind of coin the phrase. I want us to all be saying this is, is some care not better than no care, right? Because he wasn't going to get neurology care in his community. So with a few emails, maybe 10, somewhere in that range, we got a yes, we'll do it. And that nurse navigator, back to the nurse navigator, took the cart, following him down the hall so the neurologist could watch his gait, had a wonderful visit. So we're tearing down those provider reluctance walls, which I think, that's one visit in a whole host of, no, we can't see that one via telemedicine, but it's a step.
Okay. Thank you. Okay, so we've got a few minutes here that we can do some Q&A if anybody has more specific questions on this first principle and how folks are addressing it. Yes, we have had some sound issues. Apologies for that. I think they are fixed at the moment. But if anybody online or in person here has any questions about any of these, okay, then we are just going to move on to principle 2, and we will we'll have time at the end of principle 2 as well if anything comes to mind. Oh, wait. Yes.
On your do people just get something to the online schedule?
So I'm just going to repeat the question so the folks online can hear. And the question was about the standalone clinics and whether people could just show up to them or whether they needed referrals.
So we have the urgent care on demand that we could use there. I don't think anybody's using it. What we did, my marketing department, my team is unbelievable. My marketing department, when we saw this provider reluctance, they started mailing and worked with my telemedicine director's right over there. So started working with my telemedicine director and mailed all of the people in the community who were patients. And so we now have this access to help with that. So now we've created this pull from the providers. So a piece of that is self-scheduling. So they call the hub and say, hey, can I see my oncologist there? Can I see my weight loss doctor there? And we do kidney transplant patients there, do about anything you can think of. And then the other piece is the nurse navigator is surfing their schedules to see, oh, I see you have Mr. Smith coming up and he's in my region. Can we see him here so he doesn't have to drive and pay $16 in tolls or $25 in tolls, depending on where you're coming from in the state to be seen there. So a little bit of a blend.
Yes.
Sorry. Caitlin, your outpatient clinic, what platform are you guys using to add that all into that clinic visit?
So there's two. Oh, sorry. Did you want to repeat the question?
You can go ahead.
So we have two different platforms that we've been using for these visits. We do have, for all of our outpatient visits to home, we have Zoom embedded within Epic for those platforms. We also use that for our site visits. So if you're going to another site to have your visit, we're using Zoom within Epic, but using the DH Connect functionality for our sites to connect that way, since it's not that home visit link. For our family connections platform that I was talking about, we've actually used WebEx. So we found a way that we could build an authentication code into WebEx so that it sees you as a person, not just as a device, so that it can send that link. because that's one of the biggest barriers that we've really had to all of our iPad care, is that there's not an email address or somebody associated with that. So you can't send the link, but we're able to break the rules in WebEx in order to do that.
There's one more question back there.
So for your standalone clinics, have you ran into any issues with scheduling with different specialties?
So the question was about scheduling with different specialties in the standalone clinics.
So we've given the kind of the scheduling preference. We stick with the provider. So the nurse navigator does all the scheduling. Again, utility player. It's not just all clinical there. So does all the scheduling, and in the process, that person works with the office manager or whoever they designate there to schedule the patient so the flow works well with the provider. So he may see, if he deems he may see, the provider may see, 8 to noon could be for the clinic, for the telemedicine clinic. And then noon, or it could be my 8 o'clock is, telemed, 8:15 is in person, then back in my office, whatever works for them. We try to be really flexible at this point. We've been open since, and the one that's really working well, we've been open since October. And I'll tell you, they were waiting for us to open. The day they said, hey, we're open, and opened the doors, the fax machine wore out with, I got a text that day that showed me like a ream of paper. These are the referrals that we got, which was unbelievable. But we try to, so we can keep that provider buy-in, put it in their schedule the way it works for them.
Okay, thank you. And somebody in the chat made the excellent point that we probably should have made ourselves, which is to keep in mind that not every clinical case is appropriate for telehealth, and that we have to be really clear on what cases it is useful for and what cases do need to be legitimately seen in person. I think that's something we would all agree with. Then there is a question on the hubs. How close are the hubs to the population? Is it as close as to the nearest post office?
Yes, the hubs are designed to kind of be in the town center or in the RHC that they're already going to for their primary care visits. Like I said, the hubs that are standalone, still kind of in a strip mall situation, but not performing as well as being embedded into the local primary care office, RHC, those types of locations.
Thank you. And I don't know, do you both want to take a stab at this next question, or I've got ideas, but you guys are the providers. So the question is, what do you identify as the single greatest challenge or barrier? And Lori, we see you as well if you have any thoughts on this.
Well, there are a lot of challenges and barriers, I will say. For our particular program, staffing was one of our biggest barriers, in that we were working with residents who were living in long-term care facilities and who were quite ill, both chronically and acutely. And so we really needed a staff member to be present with them at that visit. And so making sure that the facility had adequate staffing to support those was one of our biggest challenges.
Anything to add?
I don't think so.
Okay, all right, fair enough. Thank you for those good questions. Let's move on to principle number 2, if I can do that. There we go. Okay, so the second principle was around equity and accessibility. And so here, it's really about understanding who has access to the program that you're setting up and making sure that you're reaching everyone and reaching them appropriately. So the guidelines here are, that the telehealth, to be equitable and accessible, it should really account for older adults' physical and cognitive differences. I mean, this is something that is a little uniquely challenging with seniors as opposed to other groups. And so trying to understand who is appropriate for the services given these challenges, and how you can maybe arm them with somebody with them, or use caregivers, or how you can use other kinds of resources to make sure that you are providing this care to folks despite some of these challenges. Then there's, of course, cultural and linguistic differences, which I would say are probably also a little bit more important for seniors in this space than maybe others, in terms of they don't always have, the other kinds of resources or abilities to go look things up on their own. So it's really important that they understand kind of the context of their conditions and their options. And so really thinking deeply when you design your program to understand how you can address these issues is important. Same thing for technology literacy and readiness. And I think there's a big need out there, going back to sort of one of those questions, what's one of the challenges? This is a challenge, I think, for providers to understand who is kind of ready, who's got the access, who's got the literacy to make themselves really have effective telehealth with older adults. That's a place that I think there's room for growth. Another guideline here is to use telehealth to address needs across all care settings. So this is really in support of just understanding that you might be reaching older adults in many different kinds of locations. They could be living alone or, in a multi-generational family setting without privacy. They could be in a congregate housing or institutional setting. And just, making sure that your program doesn't just isolate or exclude folks because of those things, but that you have processes to be able to deliver in different care settings is important for seniors. Also ensuring that staff and providers engage in ongoing education around best practices. I think this is particularly important given that we don't know a lot right now. I mean, we're presenting these as principles and guidelines. We've done a lot of work with a lot of stakeholders to get here, but there's a lot of work to be done to know, to really get data on what drives the best outcomes for older adults. And so, as that sort of knowledge base grows, it'll be important to continue to engage with the education and continue to learn with sort of the larger group. And then finally, I kind of already talked about this, but accounting for differences in access to technology and connectivity. And so, having metrics where you're kind of understanding who you are reaching and who you might not be reaching, and trying to come up with ways to reach those who have some access issues is important. And here's just one sort of example of the importance of keeping some of these things in mind. This is again from the Kaiser Family Foundation, and it's looking at these access issues. So having access to the internet, ownership of a computer, ownership of a smartphone. If you look at the blue lines, the one at the bottom is age 75 and up, and you could just see that those are the folks that are less likely to have access to these technologies. And I don't think anybody here would want to say, well, then they just don't get telehealth, but it does create a barrier that folks have to plan around. There's also differences in access to the internet and to technology when you look at urban versus rural, as Rebecca has mentioned, and that's again something that you have to come up with creative, maybe hub, solutions to address. And then finally, we see some race and ethnicity differences where Black and Hispanic older adults are less likely to have the access than white adults. So we would just say that, we would hope that as people design their programs, that they're also kind of tracking who they're serving.
All right. So kind of some examples about how we try to address equitable access to our program. One of our goals was to work with any and all facility who wanted to work with us within the state of Virginia. We had our nurse liaison, which again was our kind of pivotal person, our point player, who was working to connect with every facility we could possibly get a phone number for. Essentially, we would one thing that we found initially was that there was no kind of one best source for all long-term care facilities in the state of Virginia. There were different pockets of our case managers and different people who would keep records of different facilities that we could reach out to, but in terms of really having one all together, and so that is one thing we tried to work on as well. But the facilities that weren't the best connected perhaps were the ones that needed us the most potentially. And so really trying to ensure that we're reaching out as much as we could with any facility. We were able to get grant coverage so that we were able to provide the technology. We were able to drop that off, teach, and provide the technology at no cost to the facility. They had no commitment to continue working with us. They didn't have to become our patient. We were consulting. And so they really had no long-term commitment with us. We were trying to connect with every facility, and we were certainly open to every facility, and wanted to provide the ability for anyone at any nursing staff, anybody at any of these facilities to be able to ask the expert, right? Some of the facilities that were well connected to a lot of different specialties could perhaps, basically phone a friend, so to speak. As we're seeing COVID come through, how do we prepare? How do we get our infection control right? Well, that's great for the facilities that are well connected, but what about the facilities that aren't well connected? And so we really wanted to make the resources that we're developing as an academic medical center available to all. And so we would have these daily office hours, just open sessions really, where anyone could log on from the facilities, could log on, ask a question, talk through what's worked for you, what's worked for me, what hasn't worked, to be able to have access to that information as well. Next slide, please. Pass it on.
So for this slide, I'm going to really focus on our outpatient virtual visits that we've done. So pre-COVID, a lot of our outpatient virtual visits actually took place to patients at other sites and other locations. However, it was 4 or 5 a day. It was very small volume. During the pandemic, when we increased over 2,600 a day, we started focusing on patients being at home and not at other sites. And we had to do this because it's required for us to have contracts at all of the locations that the patients are at, as where the patient is the originating site for the visit. And on top of that, a lot of those places were clinical locations where it would require our providers to get credentialed at those locations. So several contracts, having to credential all of these providers, it really wasn't something that we could manage. It was just too much. So we've gone down the path of really focusing about providing this care to patients at home for their virtual visits. I'll start by showing this graph that we have. So this is our outpatient virtual visit failure rates. What this means is that the patient was scheduled for an outpatient telemedicine visit with video, but somewhere along the way, something went wrong and the end modality was actually audio only, not video. So it was some kind of technology barrier. Either they didn't have the right technology, they couldn't get the video to work. We're very rural up in New Hampshire, so they didn't have the bandwidth to do this visit. There's many things that could attribute to why that failure happened. We then looked at it broken down to patient ages. So the blue graph shows, or the blue bar shows 0 to 18. The orange bar shows 19 to 40. Gray is 41 to 64. And then that yellow is 65 and older. So we constantly see that 65 and older has the largest failure rates. This is just a quick snapshot from some of our data. In August, we kind of started our second spike of the pandemic. So that's why those August numbers are up a little bit higher. We really tried to focus in on patient and platform education because we felt that's what was missing, right? These elderly patients are now isolated at their home. They can't see their family members to help them set up these video visits. They've never done this before. It's totally new. So what me and my medical director, Dr. Mackwood, started doing was actually platform education sessions for these patients. So we would set up Zoom meetings, which it's kind of hard to get them onto the Zoom meeting if that's where the visit is, but we would send out good information, instructions on how to download that, send them direct links, telling them to use their web browser so they don't have to download anything. And then we would spend 30, 45 minutes just providing education to them on what is telemedicine, how does that get billed, what is it going to look like, how do I get to the platform, how do I do some quick troubleshooting. So, and we really focused it on that age group because we knew that was where our biggest issues were. Coming out of this, I think it does highlight the need for audio only services. We always prefer that video is utilized. It really enhances the visit, but sometimes audio only is fine for the kind of visits you need. And if it's not audio only for a lot of these patients, it might mean no care at all, right? You're 2 hours away. You don't have transportation to get to the visit. At least connecting by somebody by phone is better than nothing, which is unfortunate in the day of age we're in. You'd like to think we can provide care for any patients who need it, but that's the reality for some of our patients up in New Hampshire. Another interesting data point was that 52% of telemedicine visits for patients 65 and older were scheduled as audio only, especially during the beginning of the pandemic. And that doesn't even include all of these failure rates that we have here, because those we counted in our data collection of video. So it's just really that importance of needing that audio only care to really ensure that all patients have that same level of high care that they can get regardless of where they're located.
Okay, so on number 3, equitable and accessible. Again, this is the CAMC interpretation. And for this one, I want to focus on the guideline that says accounts for differences in access and technology and difficulty. So remembering West Virginia is older and rural, and oh, by the way, terrible, terrible, awful broadband. So we're like ranked 45th in broadband access across the US. So the telehub is what we're thinking is how we hardwire video. And so I have recently had the opportunity to go and observe in one of our primary care offices. And it actually is one of our primary care offices, which is really actually considered kind of metropolitan. It's the second growing area in West Virginia. Watching this awesome diabetes visit. Patient really interacted. She's cheering for him. He's done so well on his A1C. The video drops. And I'm like, so a week later, I get this invitation to go meet with Senator Capito. So Senator Capito from West Virginia, big with the FCC, working on a lot of broadband issues. So was able to go in and share with her that actually 70% of our visits are audio. So we're talking about 70% of audio. So that's what I'm talking about. CMS threats. I think what's a concern for us as the public health emergency rolls out is audio only being considered for reimbursement. That's going to be huge for West Virginia and apparently for New Hampshire as well. And the other one for me is MSAs. So these metropolitan statistical areas. I've been at a conference before, one of the ATA Edge conferences, where we were able to talk about those, and can we do anything about this? Because if those come back into play, they consider there's a hospital that's one of our partner hospitals. And I raised my hand and said, hey, to drive to this hospital, there are chickens running across the road. So this metropolitan, can we reevaluate? Can we look at that? So if those things come back in play, I have a lot of concerns for reimbursement and for being able to continue these services. So again, bringing that all back to the hub, some of the things for equitable and accessible. So, the requirements for interpreter services. So we have those little iPads that probably everybody has. We have the same requirement in the hub as we do the hospital. Now, what I'm really hopeful for is I think the platform that we use is going to be embedded into the platform coming real soon. And then technology literacy is not so much of an issue in the hub. And so when I think about, the area that I'm from, if I go into the AT&T store, I just want to buy a phone or a watch and I want to get out of there. But I pay attention to what everybody else is in there for, as I'm waiting in line. And it's, hey, my email doesn't work. Can you help me? Or I can't read this little print. That's what people are using the AT&T store for in my area, is technology assistance. So if you will, our hub is the AT&T store of telemedicine. They're coming in there and getting access from that nurse navigator to get connected and get over that fear, or how do I work it kind of thing. And maybe even get access, learn how to do it from home. And then I wanted to share, this is something that we put out on, I think we put this on Facebook or, one of the social medias. This is a direct quote from a patient. I'm not kidding when I tell you they are all saying this. And I went into the hub, I won't read it to you, but I went into the hub we had 14 or 15 cardiology visits scheduled the other day. And this lady comes in, and they were older adults, comes in with her husband to bring him to his visit. And she says, now, can I transfer mine here? I want to see my doctor here. And he wasn't our employee, so we weren't able to do that. But they're all, that the word's getting out in that community to be able to use our hubs for equitable and accessible and hardwired to video. So I think that answers that audio question.
All right, thank you. Does anybody have any questions that they would like to raise? I'm going to do that every time, I guess. Yes.
This question's for Katie. So you listed a lot of telehealth services that you're providing. And some of the ones that you listed, I know you can't be doing with Zoom and WebEx. So how many platforms and technologies are you having to use today to piecemeal together all these different services you're providing?
In total, it is 3 different platforms. So for our outpatient virtual visits to patients at home or other facilities, we're using Epic and Zoom embedded within Epic for those visits. For our family connections and some of our group visits, we're using the WebEx platform. We do have the functionality to use it within Zoom. However, some of these groups, they might be for psychiatry diagnosis or diagnosis where you don't want the patient's name showing and visible to others, where they want to kind of hide their names from others. So we've been using WebEx for that because we find that that's a bit easier for patients to preload what their names are going to be, so we don't run into that issue. For our site-based telemedicine visits, we have kind of 2 platforms that we're going back and forth on, but we have our carts and or the hardwired beds that all have SIP addresses on them that connect to Zoom or VidWio. So for most of them, we've been using VidWio for a long time. It's a nice little easy app where you can just hit join room and you're connected. ICN, we struggle a little bit. We wanted to migrate to Zoom, but in the ICN space, Zoom doesn't really have a great feature of joining a room at the same time. So it's iPad to iPad because we want where the baby is, it's a small area. You want a small, iPad. You don't want a huge cart in the room. You want to be able to remove it and quickly get in there. And Zoom didn't really allow us a great room connection feature. So we've gone with VidWio for that because you can join Monadnock ICN or whatever that facility ICN room is in order to make that connection. So really it's those 3 platforms.
So are you using VidWio then for your telestroke program?
Most of them are using VidWio, yes. Some of them have the option of using Zoom if they really want to. We have both of them hardwired into the cart so that they could use either one, but 90% of the time they're choosing to use VidWio.
Thank you.
Failures.
Yeah, so for the group, the question was about our failed video visit data and if we can notice any similarities within the patient diagnosis. And what we've started to do is look at it by department. So we've started to look at what are the failure rates for the psychiatry department versus the GI department versus endocrinology. And we haven't really found great data that leads us to that answer. What we have found is that each clinic is doing their virtual visits slightly different, where GI actually has a patient navigator that is calling these patients, especially the older population of patients, calling them before the visit and actually doing a test call with them. They had grant funded to get that position. We all know staffing is not an easy thing to come by right now. So they had that grant funding to help them. But some of our other departments that don't have that is where we see more of the failure rates. So we haven't really figured out the diagnosis yet, but we are starting to uncover some of those other layers that are with it. Yes, so the next question was about our rehab services, which is actually a slide I have next time. So I can get to that there.
So good. Stay tuned for that. Yes. So we did have a question come through the chat. What interventions have been or are being taken to increase broadband connectivity so that audio and video conferencing can be increased. And I'm just going to throw that out to any one of you that wants to respond.
I can say, this is Becky from Charleston Area Medical Center. So we work a lot with Senator Capito on that and trying to get some of the Build Back Better money and some of FCC grants to bring broadband into West Virginia. I know we are a big target because we're next to last or somewhere in that neighborhood for broadband. So, you know, we're working with our elected officials on what to do. Now, some vendors that we work with promise that they can drop one of these like backpack things, a booster into a certain area. And that's our remote patient monitoring group that says, if you've got somebody in a hall, I think there's only been one that we really haven't been able to get access at all. But for the most part, they offer or say that they drop these backpacks in if they look up the address and see that they don't have connectivity through, I think it's AT&T through their towers, that they'll go out and drop a booster close to the home so they can use remote patient monitoring. So that's certain vendors may offer something like that. I'm not sure how effective it is.
And that booster is there all the time, or it's dropped just for scheduled appointments?
I think it's just right. So that's our remote patient monitoring, which is,
so it's all the time.
yeah. So I guess when we send the kit back, then they would go pick up their backpack, put it somewhere else.
Gotcha. Lori, is that something that you deal with in your area?
Very similar to what both of the speakers have said, that we also serve a rural population in part, and it's been very challenging. Even within facilities, we found facilities, you know, will have dead spots and we'll have to bring in boosters to help within the facility itself.
All right, let's move on to our third and final principle. Okay, so the last principle has to do with integration and coordination of systems and people. Here there are 5 guidelines, and the suggestion here is that designing a telehealth program for older adults, you should be integrated and coordinated in that it facilitates access to older adults' health history for providers. Obviously, this is particularly important for older adults who often have multiple providers across systems. You might be having a telehealth visit with somebody who's not your main care provider, and it's important to have that health history when possible. So ensuring that systems can talk to one another, which I know is a challenge and a barrier, or maybe coming up with some kind of creative solutions. The next guideline is around facilitating safe and coordinated transitions of care, again, particularly across care settings. Connecting crucial stakeholders throughout the entire process. We think this is particularly important for older adults, and stakeholders here we use very broadly to mean both kind of at the provider level. So making sure that, nurse navigators, different providers, different people within that system are all coordinated, but also making sure that their caregivers, their family, their representatives, when they're available, that they really are also part of the process when possible. And then this is really more about ensuring that, telehealth is able to remain, which is supporting staff working at the top of their licenses. And that's really to drive efficiency and also to make sure that there's the right people and enough people to care for this kind of influx of older adults over time. And we know that workforce is an issue across the board. So I hand it back to Lori.
Thank you. So this principle is really kind of what started our whole program. We really wanted to try to coordinate with our local facilities to have integrative care as a care communities to best provide for our patients. So some examples of where we tried to incorporate that was a direct line to our nurse liaison. So our nurse liaison had a cell phone number, and every facility that we worked with, their DON, their nurses had that cell phone number and could call, text, anytime, especially early, anytime, day or night in the pandemic to make sure that they were getting the information that they needed. We facilitated testing, so both getting testing done at facilities. So if facilities needed to do a large scale point prevalence testing or outbreak response testing, we were able to actually send people from our hospital to the site to be able to do the testing quickly. And then our lab was able to run those results quickly. And then with our nurse liaison, get those results back in a timely manner. We also had our nurse liaison who could help with not just the coordination with the hospital, but also troubleshoot from a technical standpoint, provide that technical assistance as well. And then our nurse liaison was the point person also who would schedule the consultation once it was determined that a telemedicine consultation, be that pulmonary, critical care, palliative, was what was needed. Then it was the nurse liaison who would schedule it. So by utilizing one person, that point person, that utility person, was one of the ways that we tried to incorporate integration and coordination with our program. So then other ways that we wanted to connect a facility in the hospital more directly was were our virtual daily rounds. So our virtual daily rounds that we set up when a facility was an outbreak, either kind of coming into an outbreak or in a full-blown outbreak, we set up a systematic process to be able to assess patients effectively and efficiently. And so with our virtual daily rounds, we set a time with our team, with the facility team, that we would get on. This was we utilize WebEx for this. We would get on, to meet with the the physicians, the NPs, the primary care providers of the patients. We would meet with the DON at the facility, and any other stakeholders that were involved, as well as our team. And we had a systematic way in which we would approach the daily rounds. We would assess overnight problems. We would review vital signs and look for acute changes that maybe were unnoticed. We'd look for hospital updates for patients coming out of the hospital, and then any other needs that were needed. And so the goal with these virtual daily rounds was to ensure that all the stakeholders were there together at one time to, if more efficiently, allow the nurses to speak with all the PCPs at the same time. And the goal, and we were able to maintain this, was to have this 30 minutes or less for every day meeting. And so everybody's busy, everybody has a lot going on, but that was one of the ways we could most efficiently get what needed to be done in terms of integration. We also work directly with the hospital-based teams. Again, I kind of mentioned this before, but for the paperwork that would come over with patients, notably their goals of care statement could get misplaced in the ED. They could come in acutely ill, concerned for COVID. They go directly to what was kind of becoming the COVID isolation part at the time, and then those papers could be lost from connection with the patient. And so, to ensure that their goals of care were being acknowledged and taken into consideration, and that was the care we were providing, coordinating directly with the hospital team to say, we electronically have these records, we are sending them to you, this patient is coming to you, this is their goals of care statement and their medication list, and then to be able to connect directly with the hospital team. I mentioned a little bit about our anticipated discharges. So when people were getting hospitalized from the facility, working daily in our virtual daily rounds to, again, report clinical status of different people who may be coming back in a day or 2 days as they're improving, hopefully in the course of their infection. And then we would also have our virtual daily rounds for potential readmission. So if somebody had returned from the hospital to the facility, but perhaps they're getting to the day 7, day 8, and they're getting ill again, then we could help to both identify that quickly and transfer them back if they needed to. So those are some of the ways that we try to incorporate those principles into our programs. That's my last slide.
So now I'll talk a little bit about our SNFs, ALFs, and rehab for our outpatient virtual visits. So when COVID first hit, we realized that we had a huge problem on our hands. We were trying to shut down the clinic to be all telemedicine visits. However, our geriatric patients were in SNFs, ALFs, and rehabs. We did not have contracts with SNFs, ALFs, or rehabs to provide this service. We were not credentialed at these locations to provide that service. So we almost came to a stop for a few weeks because we did not want them to leave the facility to come to a hospital. We wanted to make sure that they weren't traveling. We didn't want them to be exposed to, COVID by coming into the hospital or their travel in. So we ended up figuring out a way to create emergent contracts with these facilities In order to do these telehealth visits kind of underneath the federal state of emergency, we're going to allow telemedicine visits to happen at these facilities. So we were able to contract within both our legal department and the SNFs and ALF rehab legal department to allow that to happen to 44 SNFs, ALFs, and rehabs. None of them had technology, or they had technology, but they didn't have it set up for telehealth. We couldn't use our regular scheduled visits because they didn't have the right platform. Each one of our facilities had almost a different way to connect to our providers for the first few months that we did this while we figured out a workflow. It was a disaster. We did get through it. So then in April is where we see that first spike. Now, these are just our geriatric volumes only that I'm showing up here. There were certain facilities set up to use WebEx for these visits, certain ones that we were able to get Zoom links sent to. It was a lot of work on the support staff to actually send individual links every time that these visits happened. What we learned from this, though, is that we're now, providing treatment in a new way. So we were able to rebuild our Epic tools for the MyDH accounts so that people could get a MyDH account connect on the outside so that that person could log in and actually see a schedule of the visits and easily click on them for it to happen. And they did go out the doors and, the O2 for the billing to be appropriate. It also helped that now these patients are being seen in their clinical setting. So previously the patients were coming to Dartmouth, being seen by their provider, getting some information from the provider to go back and tell their care team at their facility. Instead, now we're providing that care to them inside their facility with their clinical team with them. So they're seeing their geriatrician or they're seeing their neurologist, endocrinologist with their support team, hearing the same information, knowing the same medications, and they can ask questions in real time about their treatment if needed. So that was a huge overcome. We're now working on officially building contracts out for all of them, so that by the end of the PHE, we're set up to continue providing this care. But that was definitely a huge leap for us. Post PHE, it will be that all of our providers, so not only geriatricians, but neurologists, endocrinologists can see these patients when they need to. We're going to start extending it to prisons as well, because that's another population. It's not really in the geriatric realm, but that's another population that really does not need to travel to a hospital unless they do need to do, some kind of physical evaluation on the patient. So that's where we're going to start focusing next. And then this is our geriatric ED program. So in working with West Health, we were able to establish a geriatric emergency department at Dartmouth Hitchcock. And also in coordination with West Health, we're actually able to be a hub for 4 spoke hospitals. They've just gone live this past year, so it's something new that we're going through the process to see what works, what doesn't work, what are we learning. But for what it provides our hospitals is a geri ED resource nurse, so geriatric screenings, support with discharge planning, support with resourcing community-based programs. So this team knows who can assist them in the community, whereas the rural hospitals have not had that many interactions with these patients or those resources. So it's really a great resource to have there. And they also help coordinate goals for care conversations. There's physical therapy services as well. So they can help with balance, falls, mobility assessments, prescribing, anything that the patient might need to take home with them. And then also support determining disposition for the patient. Pharmacy services is also included, so med recs for the patients and identifying potential inappropriate meds that the patients might be taking. These are all resources that the rural hospitals do not have. Without this service, the patient can't get the care they need at the time that they need it. So just a quick case, this happened just a few weeks ago, actually. A 75-year-old female, chief complaint, dizziness, feeling like she was going to pass out. She had taken a few medications before going to the ED, but her blood pressure was elevated. Glucose was 290. So the bedside nurse requested a telehealth visit with a pharmacist from the geri ED team, who discovered that the patient was actually not taking 3 of the prescriptions that she was supposed to. And she hadn't been to her PCP for a while. She really didn't like going to her PCP. It was further away than she wanted to travel. She didn't have that good connection. So she just stopped going. So medications weren't being taken. One medication was being taken in error. So the pharmacy was able to have this discussion with the patient in real time to express the need to take the right medications and get the right prescriptions ordered and ask her to go see her PCP. Another thing that this patient also received was the physical therapist who was able to come on and do real-time maneuvers with the patient that almost instantly resolved her dizziness. So again, real-time action taken on the patient to help her, and was able to provide her PT exercises to do once she was discharged, and also get her connected to a physical therapist. So it's just really important for these rural hospitals that they have as many resources as they can, because this patient would have been delayed weeks if they didn't get that support and they had to wait to see their PCP, or they had to wait then to get connected to PT for help. So just really the importance of having these available.
All right, so on integrated and coordinated, again, guidelines. But these two things mean something different to me, and I'm going to be really honest. So we went for telehealth before pre-pandemic. Really honest, was not interested in integrating, and I'll tell you why. So there was a big conflict in our health system around liability and ownership of the patient record. So we made this choice between medical affairs, legal, and the C-suite. We made a conscious choice to not be integrated. Fast forward to COVID, right? Another conscious choice, not integrated because I needed it fast. I didn't care if it connected to Cerner. I didn't care. I needed it turned on. My telemedicine director trained 400 people in like 2 weeks, residents, physicians, APPs, trained them to use our technology. Thank goodness we had already made the decision to go forward with the technology. So we absolutely made a choice, and we wanted to sell it outside of CAMC. So we didn't put the name on it either. So we didn't, we call it 24/7 care. So we could sell it, which actually will work well when we move into Vandalia. Moving forward, we're deciding that probably wasn't a good call. We really need this to be integrated. You need one record, to be able to see what's going on in all these different office visits, and the provider to be able to see what happened at ER visits and all others. So we've kind of backflowed into Cerner. So all new visits are documented in Cerner. Hub visits are in Cerner. Specialist visits across the system are in Cerner. These teleconsults to other hospitals are in Cerner. And then the medical record is sent out to the other hospital to include into their record. The original decision for those urgent care, that's still documented in the telemedicine platform, but it's CCDA'd back into Cerner. So we now have everything in one place, and we do feel like that is important. Didn't in the beginning, do now. That was probably a mistake. And then the coordinated piece. I think what's important on the coordination is, Caitlin mentioned something about rural hospitals. So we, in the competition in healthcare in West Virginia, we really feel it's important that these rural community hospitals continue to exist. So coordinating with them to provide, helping through the ERs is what Caitlin's doing. Our hubs, we were able to identify that they didn't have any hip replacement services in this town where our biggest hub is. So nurse navigator gets on the phone, calls the orthopedics. Would you be willing to evaluate patients for hip replacements? Sure. I need imaging. All of that imaging goes back to and is coordinated with that local community. So they're getting the revenue for that. They're doing that. If the patient does require surgery, they'll come to Charleston, get their surgery. They can get their PT. They can get all that kind of stuff back at home in their community. So we're helping these local community hospitals to stay alive. And it, you know, nationwide, I know in West Virginia, we've got hospitals closed. And if you read the Beckers, you know, open Beckers every month, and it's, you know, how many hospitals are closing. So I think that's where we see, you know, the coordination. And then I think coordination on the other end of that is with the providers, and the way that we are increasing the provider usage of telemedicine is coordinating with them, letting it be on their schedule, how they want to see it on their schedule. I've had multiple meetings with providers to say they're up in arms about what is this telemedicine? But we are a tool. We provide a tool for you to use how you want to use it. We're not designing this upon you. We want to work with you to decide how you want to offer it. So that's been really successful way to say that to the providers to increase access and coordinate with them.
All right. Do we have any questions on this area?
First, I just want to say, Rebecca, I don't think you were wrong in not integrating first. In the middle of a pandemic, you just needed to take care of your patients. That was number one. But for the panel, what are some of the pros and cons to integrating with your electronic health records? Because I know there are pros and cons. I'll list one of the cons I've ran into, that patients have to have an email account in order to have a portal account. And so what do you do with patients who don't have email access? Do you train them on how to have an email account just so that you can sign them up for your portal? And as we think about that, is that the right tactic? Or should we be pushing back on the vendor to have other options?
It's a great question.
I think in our experience, we actually started the pandemic on a different platform that was not within Epic. Sorry, I don't know if that's really. So we had started on a different platform that was actually not within Epic, and we made a change about 3 months into the pandemic because we realized that platform was not doing what we needed. It wasn't integrated enough with what our patients needed. So we did make that move, and there were several barriers still for patients to be able to get portal accounts and those kind of things. So we've pushed back and we've said that this doesn't work for that patients. Some of them we've got workarounds of how to just send a link to join a video visit so that the patient doesn't need an email or even a portal account to have a video visit. But we took the route of pushing back to make it as easy as we could for the patients, because asking them, create an email address, learn how to log into the portal. This is where you go for your link. The more steps, the more barriers it is for them to be successful. So we went the route of pushback.
Yeah, and I think the other one is download an app. And in the case of Zoom, download 2 apps, right? You've got to download the MyChart app and you have to download the Zoom app in order for you to connect. Now, what if you have a government issued phone that doesn't allow you to download an app? What if you can't remember your Apple ID? I mean, there's just a host of barriers to having to download these apps in order to get somebody connected.
Yeah, and there are workarounds with that. So we've been able to do it so the patient doesn't have to download anything. So the way we were able to make that work was by sending them the link to join the virtual visit. So no MyDH account, but we can send you a one-way text message from Epic or email address or link from Epic to join that video visit. And then they just click on that link. And as long as they're using their desktop computer, they don't have to download any apps for that. It's really when you're using your tablet or smartphone that there's that barrier. If you're within Zoom, they are going the next route of using WebRTC as a way to connect. However, that has limitations on how many people can join the visit at the same time, or you can't share screen to show test results to the patients anymore. So of course, here's a better option, but here's more barriers put on top of it. So totally get the pain.
Push back on Zoom and Epic, we use both, and we got out of the download for everybody. And everything. Still need email address for my.
Okay, so there's ways to get around it now. Okay,
And
I may want to talk to you about that after.
Every upgrade, they're introducing more workarounds because of this exact issue. We're all saying, no,
Good.
it's not going to
Good news.
Sorry.
That was the exact reason we went outside of Cerner, was so they wouldn't have to use I don't think ours is called My Chart, ours is called something else, but they would not have to use that. However, they had to download and that, had to do all that stuff until COVID hit, and all of the clients of the platform that we use said exactly the same thing you guys did. This is not working. We need a text link. So, we moved forward with a text link at that point.
Great. I think we have a question for Rebecca. How does the West Virginia Health Information Exchange assist in providing information to and from providers when they're being seen via synchronous telehealth?
Well, I'll be honest, my organization has not mastered the art of sharing with the West Virginia Health Information Exchange or the other exchanges that are out there. So that's not something, we typically are exchanging within employed providers and what's in Cerner.
Okay. Is same with Dartmouth?
It's pretty similar for us. The one difference is that within Epic, there is the Care Everywhere app. So whoever else is on Epic, we can get those records from those facilities transferred over to us as long as that's an established patient, and it comes automatically to us. So that Care Everywhere is really helpful, but not everyone has Epic. So there's still a lot of missing information.
Yep. Anything to add, Lori?
We're in exactly the same boat, quite frankly. We do have the Care Everywhere as well. But for a lot of our facilities specifically, they have a completely different electronic medical record, a completely different system if they even have a medical record. And so a lot of ours is, kind of printing and faxing back to the facilities to have in their chart, and then trying to get it into ours as well. But it's hard.
All right. Well, I think that is it for us. Thank you all for your attendance. And we appreciate being able to share with you today. I thought there was another slide on here, something about an evaluation, but we'll just assume that means it was all perfect. So thanks so much. We appreciate your time.